My name is Amy Harris, and I'm the manager of the Patient-Centered Primary Care Home Program. And today's webinar is going to be an overview of the 2025 PCPCH recognition criteria, which will be implemented in January of 2025. So next slide, please. So before we get started, just a couple of webinar and Zoom etiquette reminders. The webinar is going to be recorded and it will be uploaded onto the PCPCH program website. So if you want to rewatch it or you have colleagues who weren't able to attend today, they can watch it there. If you're having any technical difficulties with Zoom, can't hear, other sorts of challenges, go ahead and just direct message Susan Elmancy from OHA, and she can help you figure out what might be happening on the Zoom side. And then if you feel comfortable, we'd really like folks to have their cameras on and then put your name in your view along with your organization if you feel comfortable doing that. And then if you have any questions or comments, things you want to contribute or you want answered today, you can go ahead and put those in the chat. And for now, we do have a couple of sections during the presentation where we can answer questions. So we'll just save those for the question time as we go through the presentation. So, okay, next slide, please. Okay, so here's our agenda. I'm going to begin with a overview of the Patient-Centered Primary Care Home Program. I know probably most folks on this call are familiar with it, but it's always nice to get a little refresher on what the program's all about. And then I will talk about how the 2025 standards were developed. And I think it's really important for folks to understand kind of our process and where we got our feedback and how these standards came to be. And then after all that, I will give you an overview of the standards. And then at the end, I'll share some additional technical assistance resources and let you know about the additional webinars and opportunities that we have coming up this year for you to learn more about the individual standards. So next slide, please. Okay. Great. Okay. So the Patient-Centered Primary Care Home Program was established in 2009 by the legislature as really part of the state's broader transformation goals and to improve Oregon's primary care system by developing a set of standards for primary care practices. After the legislation was passed, a voluntary advisory committee partnered with OHA to create the PCPCH standards. The committee is reconvened every few years to review best practices, clarify existing measures, and refine the standards based on lessons learned in current research. The recognition criteria has actually been revised 5 times since 2009, with the 5th iteration being implemented in 2025. We're on our 5th iteration of the standards. PCPCHs have really been central to advancing health system transformation for over a decade, and they really are part of nearly every state initiative, including CCOs, primary care payment reform, and the Medicaid waiver. There's been several evaluations of the PCPCH program over the years. The most recent report by researchers at the PSU OHSU School of Public Health compared costs and utilization for patients in PCPCHs to patients that were in non-PCPCHs. And the study showed a cost savings to the health system of $1.3 billion over the 8 years of the program. And that is attributed to the PCPCHs that really had lower costs of care for their patients compared to non-PCPCHs. In addition, PCPCH patients experienced lower utilization rates of inpatient services, radiology, and emergency department compared to those seeking care in non-PCPCHs. So next slide, please. So there are over 600 recognized PCPCHs across the state. There are PCPCHs in 35 of 36 counties. Gilliam is the county. People always say, what county is it? It's Gilliam. Gilliam's a county that doesn't have a PCPCH. The practices range in size from a practice with just one provider all the way up to large multi-specialty practices with over 50 providers. Nearly every practice type that provides primary care is represented in the PCPCH program. So this includes family medicine, internal medicine, pediatrics, school-based health centers, rural health centers, FQHCs, behavioral health organizations that have integrated primary care. They're all represented in the program. So in 2022, 94% of CCO members received their care at a PCPCH. And overall, about 75% of people in Oregon get their care at a PCPCH practice. So next slide, please. So the PCPCH model is defined by 6 core attributes and 1 foundational attribute, equitable, which was added to the 2025 standards. The equitable foundational attribute really means that equity is the foundation of a PCPCH with equity-focused standards and measures throughout all 6 core attributes of the model. Each of the standards includes up to 4 measures that demonstrate how a practice is meeting the standard. Practices apply to become a PCPCH by attesting to meeting measures. There are 13 total must-pass measures, which all practices are required to meet. And then there are 50 or so optional measures that are worth 5, 10, or 15 points, depending on their complexity. And then a practice achieves a tier level based on the number of measures that they're meeting, and they get a point total for that. And that is what determines the tier level. Okay, next slide, please. So the PCPCH program provides lots of different support and resources to primary care practices across the state at no cost. Our team conducts site visits to practices to ensure that they're meeting the standards. And we also provide up to 6 months of individual practice coaching following a site visit if that's needed for the practice. And it's often needed, actually. We're happy to be able to provide that to them. Last year, our team conducted 104 site visits that were mostly to PCPCHs that had never had a site visit before. And so they really benefited from the comprehensive services and support that they got from our team. In addition to site visits, we also assist practices by answering questions about the recognition standards as they are applying for recognition, and also giving them support as they figure out how to fill out the actual application. So we do that as well. We also create webinars and host learning collaboratives about primary care topics. There are about 2 learning collaboratives every year, each with 3 sessions. And those sessions always include presentations from PCPCH practices. So we're always happy to have the PCPCH practices come and share during those learning collaborative sessions. And then on our website, practices can find a technical assistance resource library that includes lots of toolkits, templates, policies, research articles, recorded webinars, like this one will be there, and extra guidance documents about the standards to really support practices in their work. And lastly, we publish a monthly program update with information for practices and partners, really about things that might be upcoming or changes to the program, things that we think practices might be interested in learning. Again, all at no cost for practices. Great. So the program surveys PCPCHs that have had a site visit, and we use this information to improve our program and our processes. So overall, practices are really grateful for the support that they receive from the program. So here I just pulled out some recent quotes from surveys. There's questions that they answer on a 1 through 5 scale, but there's also opportunities for the survey for people to write comments. So these are just some of the comments that I pulled from recent surveys. So I'll just pause here for a second so you can read them. Okay, let's go ahead and move on. Thanks, Rachel. Um, okay, so now I'm going to talk about how the standards were developed. So this graphic illustrates the process that the program has been going through since 2020 when we first began this work. We started with the development of OHA's definition of health equity, which was developed by OHA in partnership with community-based organizations. And then our commitment to supporting a primary care health system that meets the needs of those who experience inequities. So between 2021 and 2023, the PCPCH program gathered community feedback about primary care from the community. And we partnered with an advisory committee to intentionally focus on improving equity in the PCPCH standards. And those new standards were just published a few weeks ago at the end of March. And then over the next year, our program staff will be providing educational opportunities so that practices can begin applying under the new standards in 2025. And I'll describe this process in more detail on the next couple of slides. So I'll provide some additional content on this. So we want to move on. Great. So the COVID-19 pandemic really highlighted the fact that the current primary care system doesn't meet the needs of everyone living in Oregon, especially those who experience inequities. So these inadequacies really led to OHA's commitment that the PCPCH program will support a primary care system that really helps to address those community identified needs so that all people in Oregon can achieve optimal health. So the 2025 PCPCH recognition criteria was really intentionally developed to help practices build that capacity to help address the inequities in their patient population. And these new standards align with and support OHA's strategic goal of eliminating health inequities by 2030. So next slide, please. So with that in mind, I want to share OHA's definition of health equity. I'm sure some of you have probably read this before or seen this before. Maybe some of you even helped develop it, but some of you may have never seen it. So I wanted to share that. I think it's important to note that this definition and the 2030 strategic goal of eliminating health inequities is the work of OHA. And it's also the work of those who partner with us. So I'll just pause here for a moment so you can read that definition. Okay, let's move on. Thanks, Rachel. So as I noted in the timeline graphic, we started developing the 2025 standards by gathering feedback and input from the community about their experience with primary care. And our first step in this work was to convene an internal OHA work group to help us gather that information. We were joined by our colleagues from the Community Partner Outreach Program, or CPOP, the School-Based Health Center Program, the Primary Care Office, and the Healthcare Provider Incentive Program. Community feedback and other information that we gathered was published in a report. So the report includes an environmental scan, literature review, and data analysis on primary care and equity. It also includes an analysis of previously published reports, needs assessments, and surveys to really understand what information had already been shared with OHA and been shared with other community organizations and within other community organizations. And then finally, the report also includes feedback from the listening sessions that we conducted. So the PCPCH program conducted our own listening sessions, and that also is part of that report. So next slide, please. So this is some of the organizations and practices that we met with during those listening sessions. So as you can see, it includes statewide and local organizations, different commissions and committees, as well as primary care practices and primary care practice organizations. So during those listening sessions, we asked the same 5 open-ended questions. And if you're curious what those questions are, you want to know more about the methodology, it's all in the report. But we asked those same 5 open-ended questions during all of our listening sessions. So next slide, please. So as you can imagine, we got some really informative feedback during those listening sessions. Those are some really great organizations that you saw on the last slide, and they really provided us with a lot of really helpful information. During this presentation, I'm just going to highlight some of the key themes that we heard during those listening sessions. But again, I would really encourage you to read the full report. We have a lot more detail about what we heard from different community-based organizations during those listening sessions. I'd encourage you to read that. So lack of culturally responsive care was a prevalent theme. Listening session participants described challenges with interpretation services, the dismissal of their traditional or cultural health practices like herbal medicine or acupuncture, and that patient education materials and documents were not culturally specific or translated into a patient's primary language. Health literacy is also a barrier for many people. Documents like intake forms, after visit summaries, billing statements, and patient education materials are really difficult to read and understand for many people. Listening session participants also discussed how the healthcare workforce is really under-equipped to meet their needs. There is really a lack of diverse providers, clinical staff, and leadership within primary care and the health system in general. And there aren't enough traditional health workers that are being utilized within primary care. Some listening session participants described distrust of health providers and the healthcare system in general. Reasons for the distrust included discrimination, historical trauma, fear that providers would judge them for their health concerns or make assumptions about them, and then simply not enough time with providers to build a relationship. We heard that a lot from listening session participants as well. They wish they had more time. And the cost of medical care is still a barrier, of course, for many people. Listening session participants noted the high cost of health insurance premiums, copays, deductibles, and other out-of-pocket costs. So even when folks do have insurance, oftentimes there's barriers with cost sharing. And then also sometimes patients don't know if their other services that they're being referred to outside of primary care are going to be covered by their insurance. So we heard cost actually came up a lot. Next slide, please. So after we finished gathering our community feedback, we convened a standards advisory committee. So there were 21 people that were appointed to the committee based on their knowledge of primary care, their commitment to improving health equity, and their lived experience. The committee members were from primary care clinics, community-based organizations, CCOs, health plans, and other health-related organizations. The community feedback that we got from the listening sessions was informed the committee's work as they were revising the standards. The committee met 9 times over several months, and their recommended revisions were published in a report in April of 2023. So following that report, the PCPCH program staff gathered additional feedback from community partners and folks that we had not yet heard from, and made further revisions to the proposed standards. And then the final revisions were adopted by OHA as the 2025 PCPCH recognition criteria in November of 2023. So next slide, please. Okay, so I'm going to pause here and just see if we have any questions in the chat, or if folks have any questions, or if you want to have a question, you can put it in the chat and we can answer it. about what I just presented on. So the next part of the presentation will be actually about the standards themselves, but I just want to see if folks have any questions about what we just covered or what I just covered. Great. I don't see any questions, but I do see a comment from Gary at Asante. Thank you for saying that, Gary. Gary writes that site visits have been a great learning experience for our clinics and providers. So thank you, Gary. I appreciate that. Okay, well, if there's no questions, oh, it looks like there is. Okay, so Candace asked, is there a list of PCPs offering assistance to other PCPCs in the program? So I think what you're asking, Candace, is are there a list of practices that we can partner other practices with? And so the best or providers to act as mentors. Yes, okay, Fear, yes. So that's a great question. So yes, if you have, we work with a lot of practices, like you just saw, we did 104 site visits last year. We work with a lot of practices. If you're, we don't have a list of practices that's published, but if anyone wants to connect with a practice, or you think, gosh, I'd really like to know more about how this particular thing like is working, or how a similar practice might implement this, reach out to our program, because we have practices do that all the time, and we can definitely try to connect you with somebody who might be a similar practice or have a similar challenge. So definitely feel like you can reach out to us. Yes, you can reach out to the OHA PCPCH program, and our email is at the it's on the last slide. Yeah, of course. Yeah, great. Okay. Well, if there's no other questions, we'll get into the standards. Okay. Okay. Great. Okay. So most of the current standards and measures have been revised to improve equity. For example, there is a measure about providing telehealth in a patient's primary language. There's also a measure for collecting and documenting real D and SOGI data in an EHR. Another measure assures that referrals and patient education materials are culturally and linguistically appropriate. And there's a measure about PCPCHs providing services in an alternative setting, such as in a mobile van or in a community-based setting. Next slide, please. So other standards and measures were revised to reduce administrative burden for practices applying for PCPCH recognition and to align more closely with the current workflows and practices in primary care practices. As I mentioned, we see a lot of practices, so we know sometimes what we have in our technical specifications may not align with what's currently happening in practice. So we really tried to make some revisions to improve that. So here's some examples of what you'll see in the 2025 standards. The CAP survey tool will no longer be required for the patient feedback measures. Practices can use alternative survey tools that will be more useful for quality improvement and also be more accessible for their patients. PCPCHs will select quality and utilization measures from existing metrics lists, such as the CCO metrics list or the CMS Medicaid adult or pediatric core list. So there won't be a PCPCH metrics list anymore. You'll be selecting from existing metrics lists. So that might make things a little easier to align and support with other programs that you're participating in. Practices can translate documents into languages other than English that are prevalent in the community, not just in the practice, which is what the current requirement is. So they can look outside of their current practice and look at the languages spoken in the community. We removed a lot of outdated processes and tracking requirements that were in the measures. So we went through those and removed a lot of those tracking requirements that didn't feel relevant anymore. And for nearly all of the measures, a practice will actually need less documentation to demonstrate that they're meeting the requirements. So we really went through those documentation requirements for every measure and said, do we really need this? And can we just get away with this? And so I think as you look through the 2025 standards, for those of you who are familiar with preparing the documentation, I think you'll find it significantly reduced. So we really hope that those are welcome changes to the practices and that it makes things a little bit easier to apply and reapply and be ready for a site visit for our program. Okay, so next slide, please. So there are also three new must-pass measures that were added to the standards. Brings the total from 11 up to 13. We've had 11 must-pass measures since 2017, so we've added 2 more now. There were actually 2 current must-pass measures that were combined into one measure. So in case you were wondering what was going on with my math there. So now there are 13. The first 2 measures that are on the slide, 4F0 and 6D0, are current measures that nearly all practices are meeting. So when we talked about this with the Standards Advisory Committee, we looked at data and looked at how many practices had attested to meeting these measures. And nearly all practices are meeting those 2 measures. And so it felt like the right time to transition them to must-pass measures. And then the last measure, 6E0, is a new measure that is equity focused. So this is a new measure, and it is a requirement. Practices will have a lot of flexibility in how they can meet this measure. And we describe all of that in the technical assistance guide. But I would really encourage you to read the TA guide and read the examples that we have and reach out to us if you have questions about it, because it is a must-pass and it is new. And again, we're really flexible about it. We want practices to be doing this work, but we also want to be mindful that it's new. So we want to give you a lot of different opportunities and flexibility to meet that measure. Okay, so next slide, please. Okay, so there are 3 new optional standards that were created to improve equity. The first is a healthcare cost navigation standard that will encourage PCPCHs to share cost information and help their patients navigate payment options. The second is a standard that will encourage PCPCHs to utilize traditional health workers. And these 2 standards were really a direct response to the feedback that we received during the community listening sessions. And finally, there's a third standard that aligns with Oregon's transition away from fee-for-service payment models toward more value-based payment models. Okay, next slide, please. There's also a new health equity designation that really encourages PCPCHs to prioritize health equity within their practice. So to achieve that designation, PCPCH has to meet 15 out of 20 equity-focused measures in the standards. And we have those identified in the technical assistance guide. So if you're curious what those are, you can take a peek at those. PCPCH at any tier level can achieve this designation. So you could be a tier 3 PCPCH and also have the health equity designation. So it's not just for those practices that are at the highest tier of the model. It's for anybody who's able to meet those standards and who wants to really prioritize equity in their practice. The practice will apply for the designation at the same time that they apply for their PCPCH recognition or reapply for their PCPCH recognition. So those 2 things will be done together. And the program staff, the PCPCH program staff, will verify that the practices are meeting the equity-focused measures before the designation is awarded. Next slide, please. So this is actually the last revision that I'll be talking about today in terms of the overview. And this revision is to the tier point distribution. So the current tier point distribution in the 2020 standards is skewed so that the top tier levels have the largest point distribution. And you can see that in the table down below. If you look at tiers 3, 4, and 5, those have the largest point distributions compared to tiers 1 and tiers 2. So what that means is that a PCPCH that's meeting significantly fewer measures. So if you think back to what I said at the beginning of the presentation about how each measure is assigned a point value, that's what these points are related to. So if a PCPCH that's meeting significantly fewer measures, so 255 points, they're at the same level, the same tier level as a practice that's meeting all the measures in the model. So all 430 measures. So that's a pretty significant difference in the number of measures and numbers of points for practices that are really tiered at the same level under the current point distribution. So the result of that is that 81% of PCPCHs are a tier 4 or 5-star. And there are no tier 1 or tier 2 practices at all. So everybody's at the top. So the PCPCH tier structure was designed, its intent is to really be a framework to encourage transformation and quality improvement. So the way that the tiers are structured now, once a PCPCH reaches a tier 4 at 255 points, there really is little incentive for them to attest to additional measures or seek opportunities to advance in the model. And that's really not what the model was intended to be. It was intended to continue to have practices work toward improving, working toward changing, working toward growing. And so the way it's structured now, there really is no incentive for that. So the redistribution of these points will do a couple of things. It will ensure that PCPCHs that are meeting a similar number of measures, a similar number of points, are at the same tier level. So there'll be more consistency in terms of the types of practices and the types of measures that they're meeting that are within each tier level. The second thing that it does is it really helps to address that issue of quality improvement and advancement that I mentioned. If everybody's at the top, there's nowhere for people to go, then there's no reason for them to try to move forward. So by reshuffling the points, as we're doing in the 2025 standards, as you can see, the tier distribution points, we're creating that additional incentive for practices to move forward. And look at different ways that they can improve or different measures that they can add rather than just getting to the tier 4 and then just stopping, which we've seen. So also one thing that you can see in the new standards is that there is no 5-star designation any longer. We've replaced the 5-star designation with a tier 5 that is a point-based only. So it's similar to the current tiers 1 through 4 in the model. So it's only based on points. There are no special measures to meet. And this change will actually make it so that more practices could reach that highest level in the model. As folks know who are familiar with 5-star, it has a lot of additional requirements. There are specific 5-star measures that a practice has to meet. And practices that don't have as many resources, they can find it to be challenging to meet all of those 5-star measures. So this feels a bit more equitable in that it's a point-based tier level only. So more practices would have an opportunity to reach that highest level in the model. Okay, next slide, please. So implementation is already underway, as you might already know. Last month, the PCPCH Recognition Criteria Technical Specifications and Reporting Guide, or the TA Guide as we call it, was published. And that provides all of the details about the standards and measures, what is required, and what practices should be looking at. So that was published at the end of March. And then really starting now through the end of this year, our program will be offering multiple learning opportunities really to help practices understand the new standards, ask us questions, help us to understand them a little better as well. The more we talk about it, the more we understand, the more questions we get, the more we're able to help you. So that'll be happening throughout this year. And then starting in January of 2025, practices will begin applying under the standards. And that will be a transition where any practice applying after January of 2025 will have to meet the new standards. So the 2020 standards currently won't exist any longer. With the intent of having as many practices recognized under the 2025 standards as quickly as we can, practices that are applying this year in 2024, they will only be recognized for 1 year. They'll have to reapply at some time in 2025 when their recognition is due for renewal. So to give you an example, if you're a practice and you are applying for recognition in 2024 or in September of 2024 this year, you will have to reapply in September of 2025. So you'll only have a 1-year recognition cycle. Again, just for practices applying this year. And the intent of that is so that by January of 2026, all practices are recognized under the new standards. So we want to get practices recognized under those and working on that equity work and working on those new standards as quickly as we can. So that's the implementation timeline. Let's move on to the technical assistance that we're offering. So like I've noted a couple times throughout this presentation, we're offering different technical assistance opportunities. The primary way we're going to do that is through a webinar series. So those are going to begin actually on the 26th, so next Friday. And we will have them every other week, every other Friday from noon to 1. And they're going to be topic specific to different standards. So we're going to be really going through the standard, talking about the standard, talking about its requirements, and inviting your questions for those standards to really help you understand them. They will be recorded, of course, so if you can't make it, they will be available on our website, as well as any additional information that we might develop around those standards will also be published on our website as well. So we'll be doing those through the whole year, all the way through December. And so definitely take a look at that document and see if there's any, you can register for them now, get them on your calendar. And then we also plan to offer, we haven't figured out when we're exactly how this format will be, but we are going to do some office hours or just some open conversation time more toward the end of the year, maybe in the fall, as practices really start looking at the standards more closely and gear up for a testing in January. But as always, if you have other questions, you can always reach out to us now. We're happy to answer any questions about the new standards. Okay, and that leads us to the resource page. So this was just a list of resources, things I talked about today. So the first is our website, our program website. So you can find lots of information on there. The second is the TA guide that I've already mentioned. So that has all of the detailed information. We also put a link to it in the chat at the beginning of the webinar. So you could take a look at that link if you want to. We also have on this resource page our technical assistance resource webpage, which is what I also talked about earlier. So where we have all of the templates and recorded webinars and the sample protocols, all of those documents are all in that technical resource library. So that's a link to this page. And then also I included the community engagement report and the evaluation that I talked about. So both the evaluation of the program and also our community listening sessions around equity, those two reports are also linked on this page as well. And then finally, our program email. So of course, you can always reach out to us, and we encourage you to do so. We welcome your questions. So please feel free to reach out anytime. Okay, so with that, I think we have plenty of time for questions. So why don't we stop sharing the screen, Rachel, if that's okay, so we can see folks. And then let's see, I don't know, Susan, are there any questions in the chat?
Yes, there are. Let me scroll up. There's a few questions. Oops, and admit someone. Okay, so it looks like the first question is coming from Rebecca, and it says, can those documents / educational materials be on the website rather than physical documents mailed or handed to patients? We are trying to minimize papers that get lost or tossed. I think this was regarding one of your previous slides, Amy, on one of the earlier revisions.
Yeah, probably on like the patient education materials and documents and things like that. That's a good question. I'm sure that makes a lot of sense to try to minimize the actual paper that gets sent to patients. And I'm sure our site visitors have probably seen practices that are using more electronic documents. So, I would refer to our site visitors who might be on the call today. I would assume that would be okay. I see Amber or Alicia. I know the two of you look at a lot of documentation. Does that sound?
Yeah, I think that's fine. We'd want to see what information is on your website, and how the patient's directed to your website to get that information.
Yeah, good point. Good point.
And we also want to double check that your patients are accessing or are able to access information electronically, or if not, that there's another route to get that information, so that if they don't have that electronic access, they can get it in another manner too.
Good point. Thank you, you two. So looks like the next question.
Yeah. Okay, so the next one is from Jamal. Can practices apply early under the 2025 standards in 2024?
No, I'm sorry. You can't apply in 2024 for the 2025 standards. The way that our application system is designed, we can only have one application going at one time. So, I wish we could have the 2025 application up, but we won't have it available until January. But you can apply early. So for instance, if you are due to apply in March or April or May of 2025, you can certainly apply in January. You absolutely can apply early. So you just can't apply in 2024. Yeah, it's a good question.
Okay, and then the next question's from Megan, and it says just applying, not reattesting.
Oh, that's a great question. I appreciate you asking that, Megan. We actually use those terms interchangeably in the program, and I apologize for the confusion about that. We call applying, that means the same thing to us. So if you're applying or reapplying or reattesting or attesting, we use those terms interchangeably. It all means the same thing. So I apologize for the confusion around that, but those two things are the same. So.
Okay, and then next question's from Ashley. So practices reapplying in 2024 will be 1 or 2 year recognition.
Yeah, great question. So 1 year. So again, if you apply now, if you're due to apply in April of 2024, you'll be required to reapply in April of 2025. So by the end of 2025, or by January 1st, 2026, all PCPCHs will have applied under these revised standards. So either you're applying, so I don't know if that's helpful. So.
And that's it for questions. The rest were replies to the information you covered. Oh, wait.
Oh, there's one.
Hold on, there's one. So again, from Megan, if we are due to reapply in December 2024, is there extension we can ask for to apply in January 2025?
Yes. So reach out to the program, reach out to Rachel, who manages our email, our program email. So yes. Other questions? Folks can unmute or you can put it in the chat.
A question. How much of an extension could be asked for? For example, we're due to apply in August of 24 this year.
Yeah, that's a great question. So by Oregon administrative rule, so within rule, we are only allowed to grant a 30-day extension. Now I'll tell you, I've been fudging a little bit on that, which I'm technically not supposed to do. So we've been granting like, you know, sometimes 6 weeks, sometimes a little longer. So definitely reach out to us. I would say August is probably more than what we can grant. But if you're due to reapply like in, late November, reach out to us, definitely do so. We don't want to cause, we don't want to cause more burden and for you to be stressed out about that piece. We can and you also might be excited about attesting under the new standards. So we can give you some flexibility there, but technically we're only allowed to grant a 30-day extension. So that's a good question.
Amy, there's another question in the chat from Christy. It says, I've not got to this part of the TA guide yet, but I'm wondering which staff are needed to be included in the trauma-informed training of 6E0 to meet the requirements for this must-pass measure.
Yeah, that's a great question. So we definitely will be talking about that at the webinar about that measure, but I'll just say now, it says in the TA guide, it's only your actual clinical providers at this point. We would love it if you provided those types of trainings or did that for your whole staff. But we know that this is a new measure. And so we want to make sure that, and so we made the decision that like the requirement is really only your clinical staff. But again, we'd love it if your whole staff could be trained. So, and eventually that will be a requirement that your whole staff is trained. We just didn't want to make it feel too much of a burden right out the door. So, but yeah, that's a good question. I think we have that in the TA guide, Joan. It says how do you define clinical providers? I think we have that written in the TA guide. We can take a look at that. If not, we can talk about adding some structure around that. So. Looks like there's another question about, so we had to attest in January of this year, so we won't have a full year of the new measures. Can we qualify if only performing at the new measures for 6 months? Not sure I understand. So are you asking if you can attest? So people who are attesting in January will be attesting under like without having been in the program for a year. So that would apply to everybody. So I'm not sure if I'm understanding. I don't know, Jolene, if you want to.
Jolene, are you asking that you have to be doing the standards for a year before you can attest? You don't have to be doing the work for a full year before you attest to it. You just have to be doing it at the time of your attestation. So for you attesting early in January, you're going to want to get a head start and look at the measures now, see what you can attest to that's new, what kind of workflows and things you can put into process now or towards the end of the year, so that by the time you attest in January of 25, these are things you already have in place when you're attesting in January. Does that make more sense? Okay.
Great. Okay, good. Thanks, Amber. It's like,
Amy, there's another question from Christy, and it said, I might have missed your answer. Does clinical providers include clinical staff such as medical assistants, or is it defined right now as the doctors?
That's a good question. I don't know. I'm not sure how we're defining it in the TA guide. We could take a look at that. We may need to put some additional clarification around that. I think right now it's just like actual doctors, so, or the actual PCP, but we can take a look at that.
Just to jump in real quick, just because I have the TA guide
Oh,
open.
good. Thanks.
Right now, it is primary care providers that have to be trained for 6C0.
Great. Thanks, Rachel.
Okay, and a comment, perhaps a silly question, but I heard you say traditional health worker several times, and it's a part of one of the new measures. Can you tell me what exactly that means?
Yeah, so traditional health worker is a sort of an umbrella category for, at least in Oregon, for a lot of different jobs and different types of care providers. So in Oregon, what falls under the traditional health worker umbrella are community health workers, doulas, patient navigators, peers. So within the behavioral health space, peers. And there's a whole, there are several other categories, and I can't remember all of them. But it is in the TA guide, and also I can, we can make sure that that's linked to. There is a whole definition of traditional health workers, and I think we have it even in the glossary of the TA guide, Rachel, too. Of what is a traditional health worker. So that's a good question, not a silly question. Other things folks want to know about? Okay, well, that seemed like a long enough uncomfortable pause where nobody nobody was chiming in. So I think we'll conclude. So again, thank you so much for joining us today. If you have any questions, please reach out to us. I've said it a couple times, I'll just say it again. We are definitely here for you. We're happy to answer your questions. And please join us for the other webinars. Again, if you cannot get that, people are busy, you can watch the recording, or we can set, or if you have questions, just let us know. We're happy to support you and help you in to understand and meet these new standards in any way that we can. And also understand that we know that we also acknowledge at the PCPCH program that change can be really scary and it can be really difficult and challenging. And so if you want to reach out to us and just talk to us about that too, that's completely fine. I mean, we work with, like I said before, our team works with so many practices. And so we really, really hear on the front lines and on the ground what's happening in primary care. And we really do understand and we really do empathize. And so if you have any other questions, please reach out to us, or you just want to vent a little bit, feel free to do that too. That's what we're here for. We're happy to do that as well. So thank you, everyone. Have a wonderful afternoon. I don't know where you are, but I'm in Portland and it's beautiful outside. So hopefully it's sunshiny wherever you're at as well. So have a wonderful day. Thank you.